In a minute.
Okay.
Hi, everyone. We're here. We made it. Whew. Okay. We've
Hi,
been
everyone.
high.
Hello.
Okay. We have Dr. Melanie who's going incognito tonight. She's
Sorry.
not feeling well. She thinks she's unpresentable. I'm going to be
I
honest.
no,
She's
I
feeling a whole lot better. We
yes.
have
Heidi,
Wit.
only for you. The only reason she's doing this is only for you.
I'm a mess.
She's a mess, but she's a good mess. We have Wit that's joining us, and we have Dr. Sasha, who is Dr. Melanie's wonderful, wonderful husband. So,
He is.
guys, we're in for a treat tonight, and we have a lot of information that we're going to go through. Dr. Melanie has an intro she wants to do for you guys, and that's going to kick us off for the night. But first of all, let's see who's in the chat so far. I don't want to get started so early. That's because
Right.
they've been getting notifications late. Don't ask me why.
No,
They're
I have
getting
too.
notifications.
I don't know. I don't know
Okay.
why.
Yeah, but let's see. So far we have Susan Dawson in the house.
Hi,
We have
Susan.
unapologetically curious. We have paranormal witch is here. Welcome. Of course, we have sassy Susie Bell in the house. Susie has been waiting for this for 2 weeks, to be honest, and she's
So
been
sorry,
asking me
Susie.
about it. My sister Edith, that's okay.
My
My
fault.
sister Edith is in the house. Rosie
Hi,
Bynum is
Edith.
in the house. Hi, Rosie. Nice to see you. Uh, and then Susie says, I really want to hear about. She's here. Cindy is in the house, so we're filling up. As we go, Melanie, and
Yeah.
Dr. Melanie. I call her Melanie when we're talking. Dr. Melanie will be taking
Fine.
questions along with Dr. Sasha. Wit will also be able to answer questions, and we all know Wit, and Wit has a wealth of knowledge. So, Dr.
Yeah.
Melanie, the floor is yours, sweetie.
Okay. So as you know, we're gonna talk about basically opioids, but my feeling is that um, the term an opioid epidemic is not only a misnomer, it makes no sense. Medications are not usually epidemics. Um, Typhus, COVID, those are epidemics. But so what it should read is opioid abuse is an epidemic. I have yet to find anyone who has written for their patient to take 8 pills at one time. It gets abused and therefore causes death. Very rarely, if used as directed, does it cause death. And mainly, as a physician, um, we'll get we'll get into that later. But the main one we're talking about, like heroin, is an opioid. But the ones we prescribe, the main one they talk about a lot is OxyContin, and then morphine, fentanyl, Vicodin, Percocet, Lortabs. I'm sure you guys have probably heard of many of these. Those are all opioids. OxyContin is about 2 times as strong as morphine. Fentanyl is about 100 times as strong as morphine, just to give you an idea. Um, it'll become more relevant as we go on. And OxyContin came to us in 1996 and was originally like the answer to every doctor's prayers because we hadn't had a PO or oral by mouth medication to treat severe pain. So, postoperatively, and for many other things, you literally were just babysitting for pain management. And this was a way to get people home, free up beds, and them not be in pain. Um, and I do also, as a side note, want to say there's a lot of bureaucratic mess with this medication. I'm sure Whit knows a lot about that, but that's a whole topic in and of itself. The black market, and where it's relevant, I'll just say the black market. But I, otherwise, I'm more concerned with the people who need this medication, that live in such chronic pain that their lifestyle is completely affected. They can't work, they can't sleep, etc. And when this, opioid crisis uh, was named in about 2016, it was technically December of 2015, but um, doctors kind of got blamed. We were directed to decrease everyone's meds. Some stopped it altogether. And there are people who now, and my mother was one of them, couldn't get to their front porch. And so the result was punishing pain. And these patients are called legacy patients, meaning they've been on them for 10, 15 years on Oxycontin, and it's saved their lives. They could work, they can function, and now are just curled up in a ball and can't move. So I, as a doctor, especially, I have a very hard time with it, and the way the media presents it is, I think, very one-sided. I think it's misleading, and there were, let's see, I believe later on you'll see a graph just showing as opioids, doctors' prescriptions have decreased, overdoses have actually increased of opioids because people are now going to the black market. And those are not safe, and they are very often laced with fentanyl, which again is 100 times more potent. So if they even take 2 pills at once, they could overdose. So it's not, it's also, yes, you can become dependent and not addicted. So you should wean off the drug slowly. I had to do it once after surgery. It was not a big deal. And it saved me after the surgery. And there, is certainly a difference between dependency and addiction. So,
Okay, so let's get
I
into
think
that because we
that's,
want
yeah,
to.
I think that's about it for
Yeah,
the
because we
intro.
want to discuss. Okay, we want to discuss the first wave of the war. The first wave, which is what we discussed. And
Right.
guys, and I went through and I put it on a PowerPoint for you. So the first wave was in 1999. And Dr. Sasha, do you want to take that one? How did that wave start?
I mean, that was, the time, pretty much at the time when, doctors were, told that the best way to control pain and deal with pain is to prescribe opioids. So a lot of the pharmaceutical companies began giving pain medications or advising doctors to write for pain medication all the time for everything. There was no thought of addiction. There was no thought of anything is too strong, and the regulatory agencies did not really care what you were prescribing, and ultimately that there was an issue with that.
Okay,
we
so
were
then
we
we
were
had
all
the
taught
second.
no we were all taught in medical school in my generation that pain is the fifth vital sign. whereas heart rate, pulse, blood pressure, temperature, and pain was now included, and we were trying to control pain all the time, and all of a sudden we could prescribe pain medications all the time. And they actually took back there. When I first started, there were triplicate pads for writing narcotics. So it was very difficult to write narcotics initially. They took that away so you could write it on a regular doctor's pad and nobody
Yeah.
cared.
I was a resident.
Mm.
I was there during that switch. And we were so happy because you had to have
Okay.
a special pad. You don't care.
And then you had
But
three, it was
yeah.
3 copies you had to send them to the state initially, the duplicates, so that they had a record of what you were prescribing, and you could get in trouble for doing that. So nobody really did it, but then they relaxed everything and nobody cared. And so we were, and that was
Okay.
in part driven by the pharmaceutical companies overall, because they were coming out with medications that were stronger, more profitable for them, and ultimately it was profits. And everybody knows about the Purdue pharmacy that came up with OxyContin, and they're now bankrupt because they were pushing the drugs so much that you couldn't believe that their drug reps were getting incentives. They
It
were getting
was
paid tons of money.
aggressively promoted. If I can just add, to the tune of sales being initially 50 million in 96 to
Billion.
$1 billion
Oh,
by 2000.
yeah, billions. And then
Yeah,
beyond that, I think it was
50
billions and
million.
billions.
It was. Right. Go ahead.
No, I'm done.
What? Where'd Whit go?
Where'd everybody go?
Yeah, where did everyone go? It's just us.
It's us.
No, I'm
Okay.
here. I'm
All right.
serious. The weather
I-
here
I'm
is
here.
horrible.
Tell
Can
me.
you guys hear me?
Now I can.
Yeah. So
Okay, the weather.
Do you
I
have
am so sorry,
anything
guys. The
on
wind and
Whit?
everything. The weather is horrible.
Yours isn't so
Okay.
great. I'm sorry.
I am so
Did Whit have
sorry.
something to say? No, don't worry. We're
yeah,
good, we're good.
If
somebody
anybody
in
hasn't
the comments
seen,
said about the Sackler family, and yes, they made billions off the sale of
Yes.
OxyContin. They were the ones that owned the Purdue Pharmacy Company, and they were the ones that produced
Purdue, yeah.
OxyContin. So they ended up, paying back a lot of money, but they were still able to probably stash a couple of billion, which most people, most families can live on.
So that
Except
was
my
that first
kids.
wave. Then we had the second wave in 20. Okay, and then we had the second wave in 2010, and we saw a rapid increase in overdose due to I think it's heroin. It was a big,
Right.
a lot of overdosing with heroin. So what was the derivative of that? I mean, because we were freely getting the medication, they were writing scripts all over the place.
Yeah, but heroin became a lot cheaper, and heroin is of all the opiates, it's really the best opiate because it's the fastest acting. So the people that are predisposed to developing addiction will get hooked onto that after 1 or 2 doses. The regular opioids that we use in medical practice, even the fast acting ones like fentanyl when given IV, or a medication called Dilaudid when given IV, is fast acting, but it's only got a short half-life. So when we started getting a lot of stuff in the hospitals, patients getting a lot of pain medications, they went out on the street, because nobody's going to say, go ahead here, have a whole bunch of fentanyl for the road.
Right.
They're going to
And fentanyl is not, there's no real oral form. There are lollipops, but there's no pill.
fentanyl patches, but
And the patch. Right.
there's no pills, so people will take
Okay.
it. People will be very creative about how they're going to inject their drugs. They'll swallow whole patches. They'll cut up the illegal pharmacists, the ones that take fentanyl patches and convert them into stuff that laces the
Oxycontin.
OxyContin and all the other, the illegal medications. The fentanyl patches, are the kind of the basis of everything. So you steal somebody's fentanyl patches, and the outside pharmacist will work on it to make it so it's injectable. And then when that doesn't work, you just go out and get
Okay.
heroin because it's cheap.
But you
Okay. And
can
So
then,
that's
still
how.
see from the
I
first to
looked.
the second. Go ahead. Go ahead.
No, I was going to ask you about the third wave because I
Yeah.
wanted to get into the uncontrollable stuff and how it's affecting, like you said, the legacy people that really need the medication. So when
Correct.
that third wave came, it was in 2013. Okay.
Right.
At that time, we saw a significant increase in overdose involving synthetic opioids. Particularly, they were involving the illegitimacy, of manufacturing. That's when the fentanyl came into play in that third wave.
Right.
That's
Yeah,
when
but
we started seeing a lot more.
I think that's all true, but it's just kind of a spectrum of, of everything.
Okay, that's what you're here for, to explain it to us. Whit, chime in when you have something to
Yeah. What?
say, when you're ready. But
So I
yes,
did
ma'am.
want to say a couple of things.
Yes.
So first of all, The Pharmacist on Netflix. I don't know if anybody has ever watched The Pharmacist, but it's literally
No.
a docuseries about a pharmacist who noticed the rise in OxyContin sales in his pharmacy. He owned his own pharmacy and he noticed the rise of sales. So he sleuthed and he literally figured out who the doctor was that was prescribing. Then there was a doctor that was prescribing, like literally had like a corner chop shop for
Right.
OxyContin
Mhm.
prescriptions and scripts. So that is a really super interesting
Yeah.
docuseries that kind of
Watch it.
delves a little bit deeper into how big of an issue this is. I think definitely
Right.
the pharmaceutical companies played a part, but I think that they probably played a part without knowing the full extent of how addictive these drugs really are. So I live in Philadelphia and we have like an enormous opioid issue. Like it's bad. We literally have a whole area of the city that is, like, they say one of the biggest open air drug markets in the United States on the East Coast, or the biggest on the East Coast.
No. Is it black market?
No, it's a neighborhood where people are literally just going there from all different areas, especially on like the Northeast, and are obtaining the drugs because they're so easy to obtain. And there's a lot,
But it's
like,
illegal. My wife was asking if it was, it's a black market. It's like illegal. It's not
yes.
a bunch of
Yeah.
pharmacists that are actually
No.
doing this.
Or
No,
doctors? Right.
it's illegal. And there
Okay.
are safe consumption sites there. So actually part of what I study in school is we learn a lot about this crisis because my school is based out of Philadelphia, and that's
Oh,
our biggest crisis
right.
here.
Right.
And we have like safe consumption sites in the city, things like that. So we're kind of at the cutting edge of implementing new technology to kind of remedy this situation. Not that anything's necessarily going to remedy, but decrease harm, if you will.
Yes, but I would just like this is a
Okay, so here's
perfect.
my question.
Go ahead, Heidi. Go.
Okay.
Tell
No,
me.
Go ahead, Melanie.
Well, I was just
Go
gonna
ahead, Dr.
say, I
Melanie. I'm
just
sorry.
wanted, no, that's okay. I just, to pivot off of what Whit was just saying, you you have to realize, like, you hear opioids, this opioid, and they sound so horrible. Oftentimes, we're talking about heroin and, illegal black market sales. We're not talking about patients living in chronic pain, going to their doctor regularly, getting drugged. It's like they made it out. It almost felt like opioid became synonymous with OxyContin, and that's just not the case. I mean, there are many opioids. So,
Oh yeah, for sure.
yeah.
For sure. Like our problem, one of our
Okay,
biggest
so
problem
here,
areas is fentanyl.
Yes. Right.
okay, so here's the thing that I'm getting from this. So people build up. I know me, my tolerance is very high towards medication. So people build up a tolerance to prescription medications. So then if the doctor is not increasing the milligrams or whatever they're issuing, then they go out and they start doing what are they doing? Self-medication because the
Yeah.
pain is so bad. And
Yeah.
what I read looking at the new CDC guidelines is that they're trying to pull people off of the opioids and and Dr. Melanie, you and I were talking about this earlier.
Hmm.
I pulled up the guidelines. Matter of fact, I have them on the PowerPoint. And from what I see, they're discouraging, and you said it yourself earlier that the doctors are
Hmm.
being punished. They're
Yeah.
discouraging doctors from treating their patients with opioids because they think that's
Yeah.
going to control that epidemic. But instead, they're causing the new epidemic of uncontrollable pain.
Right.
So, how do we get around doing that? So, that's what, yeah. How do we
I
still treat these legacy patients and all the patients that really need to have these opioids and these, how do we go about doing that? That's what I want to hear what you guys have to say on that.
well, I'll start, and I have to say, don't take them off of it. You know who your legacy patients are, you know, but I mean, they scared us to death. Sasha and I just found out another doctor that we know got put on the high prescribing list, and he's now gonna get locked up. What they never told us is what's too much, you know, and and then
Okay.
some doctors are just stopping it, which frankly is harmful to patients. The withdrawal that they go through, I mean, they can be tapered off, but I mean, I don't think we can stop people from misusing it. We can't stop people from being alcoholics, but I mean, there pain doctors now have more procedures and things that can be looked into that maybe will help, but if they don't, then I I mean, educate them
My
and
wife, she makes a great point. Alcohol is the perfect example of what, a perfect analogy. You have alcohol that's legal for everybody to buy
feel
and
like
do
how
whatever
he
they want
said I gave
with.
a perfect analogy.
What?
You're
Yeah, no, it's
scared.
perfect. Now you're going to have all these people that are going to abuse them, abuse the alcohol, you know, and you have those people that will drink in moderation and be able to function, but there are those people that will drink themselves into a stupor. That's the same thing that happens with opioids. I mean, you'll have a lot of most patients will control their pain and they'll do everything that they can to regulate their use of it, but there's a small percentage that just start going overboard. But that percentage, given the entire population of the United States, is
Right.
actually a lot of people. And so a small percentage of that lot of people, which there was a slide that was put up, 47,000 people overdosed on pain medications and died. That's a lot of people. But in and
Now,
so
when
that's how.
19 million people are living with chronic
Yeah.
pain.
Right. And so, you have to kind of, somewhere along the path, it became a very popular subject, all of this pain medication, all of this accusing doctors of overprescribing. If you take one of my average patients that may take 4 pain pills a day, just typical Norco pain patient, or 4 Norco tablets a day,
That's an opioid, so in case
that's an
that
opioid, yeah.
yeah.
And that's 120 in a month, and then you take it and multiply it by 12. That's a lot of pills. That's 1,200 pills plus another 240. That's like 1,500 pills. That's a lot of pills, and it looks like I'm over prescribing for that patient. And let's say I do that for 10 years, that's just one patient that's getting 15,000 pills from me. So now if I have 10 patients like that over 10 years, that's a ton of medication. And if somebody has a bad outcome and they start investigating me, they're going to say, "Oh my God, this guy prescribed all these pain medications, over this period of time, and I look like a drug dealer." So,
Right.
doctors are very apprehensive about prescribing any pain medications anymore.
Oh my
Yeah.
goodness.
Chris, do you see that Chris just put up the comment?
No.
You don't see it?
Oh yeah, exactly. That's the other thing now, but that's mandated by the governments now. I got to do that with all my patients. I have to see them at least every 3 months, and then I have to do drug tests and counseling and have them sign all sorts of crap. So does my wife. It's
Yeah.
just
Well, my mom had to do it every 3 months, not every month.
right.
But if she
Yeah,
called
it's
a
every 3
day
months. Yeah.
early, like after a month she needed a refill, if she called it 1 day early, she wasn't getting anything.
Right. And the
But she never
pharmacists
even
are
did.
nightmares. Yeah. They're
Well, then
awful.
we as doctors, I won't prescribe if it's not 30 days yet. But I mean, I think we have done the best we can. Our job is to help people. I'm not going to let someone, I mean, it's so sad. Mina just put up about 100 million. The estimate is 50 to 100 million people live with chronic pain, but pain that is, so severe, that you cannot work, is, and it interferes with your lifestyle and your sleep, and it just tortures you, is about 20 million. That's a lot of people.
Yeah, but
That is.
I'm looking at what Mina
And
said.
you think
Methadone,
it's
buprenorphine. Those are all, yes, they're all narcotics, and you can overdose from each one, every one of them, except for maybe buprenorphine, which is not, which is what's Suboxone, but it's not a really
some
good
people,
pain medication.
yeah, right. It's what's called agonist antagonist. It helps you not withdraw because it's got some opioid like features, but you can't get like high from it no matter how much you take.
And it doesn't work
Some
well
people,
on chronic pain.
it does now.
Okay. And I
That's
just
really
want
not
to say,
great.
I just want to say I'm sorry, but I had to move closer to my router, and my room is dark, so I'm using my picture. I'm so sorry, but I moved as close as I can to the router because I kept timing out. And this is
Okay.
really important, and I want to hear everything you guys have to say. Also,
Okay, wait, can I use my picture? It looks a lot more like Brad Pitt.
I'm sorry. And besides, I look exhausted. That's what Wit says. If not Wit, Susan told me I look exhausted. I am exhausted, but I'm going to get
I
some
told her
rest
she
this
was
week.
crabby today. She was being crabby.
I was very crabby because I'm
She was very
tired.
crabby.
I've been ripping and running for 2 weeks with my son, so I'm going to
I
get some
know, that's
well-deserved
true.
rest. But I'm sorry, but I just have to be
Yeah.
closer to my router, and the lighting and everything is in the living room, and
No one
it's
cares.
so.
You're fine.
Well, I'm just letting you know. I'm just apologizing. But to get back to what we were talking about, the PowerPoint, are you guys looking at the PowerPoint that I
Yeah.
put up there?
I mean, it's
Okay.
excellent, by the way.
Yeah, it is.
Thank
Really.
you.
Told you
Thank
it
you.
was. Look, when I told her, she's like, great. Sasha says, thank you. She's like, woohoo, thanks.
So, guys, I was looking because Melanie, with all the data that you sent to me, I saw the misguided
Yes.
federal
Regulations.
that stuck out to me. And if you look at what it's saying, it says that in an effort to address the increase in opioid related overdose deaths, government agencies at both the state and federal levels clamp down on prescription opioids in a misguided effort to
Correct.
tackle the crisis.
Right.
So, it's affecting millions of people, millions. And it said out of 50 million people live in chronic pain. 19.6 million live with, they're known as high impact chronic pain,
Right.
and affect their ability to work. So
that means
how do
high
we
impact on their life. And you think, like, I say this, we think 600,000 people died from COVID. That's a huge number, and it's scary. Okay, but we're talking 20 million. Not to, minimize COVID by any means. I'm just saying 20 million people whose lives are completely affected. They can't work. That is a huge number.
Can I say something really quick?
Yeah,
Yes,
sure.
Yes,
yes.
ma'am.
Please tell us.
So I read this comment from Shade, and I just kind of wanted to address it because I think it's a really important conversation that we need to have when we're talking about chronic pain, but we're also talking about abuse of opioids. It says addicts will find a way to abuse drugs, period, full stop. Legitimate chronic pain patients and compassionate doctors should not be grouped in with addicts. Two separate and distinct illnesses. So I just kind of have to disagree with this. And I find that comment to be super stigmatizing because being someone with chronic pain and being someone with an addiction are not mutually exclusive. So you
True.
can be someone that is experiencing both of these things.
Absolutely. There are many.
And we don't want to stigmatize those individuals and make them feel less than, because if they feel less than, then they're less likely and apt to go seek the help that they may need.
You're right. Totally
Okay.
right.
Absolutely, yeah.
Okay, look at the comment that I just highlighted from unapologetically curious. Please.
It's perfectly well said.
And I agree with my wife. It's well said. And the issue is, the problem, the issue is that when you deal with all sorts of different patients, you have to kind of get a picture of them when they come into your office or when you come into your practice, and you have to have some, not though I don't want to say suspicion, but you have to have some sense of who actually is the best
Kind of like
way of.
pass the sniff test.
Yeah, the
Like,
sniff. That's
yeah.
exactly it. I mean, if somebody comes into your office and says to you, Doc, I need 180 oxycodone tablets, and I need them. I need you to refill them every 10 days for me. You know, you
Right.
are thinking, you're thinking that they're an addict or they're selling them, or you have to have some sort of suspicion, and that doesn't smell right. Also, somebody that comes in and is crying, saying, I'm in so much pain, I'm in so much pain, I'm in so much pain, and they are telling you all of this, and yet they you know are going to go off and play golf when they leave your office. There's a lot of issues, and part of it is, you give them too much and they drop dead, you're liable. You prescribe too much of it, you're liable. And
We don't prescribe too much. They take
but
too
I mean,
much.
yes, you're right, hon. A lot of for the most part, don't. But if you start getting the reputation that you're going to give this person Norco and then this person OxyContin, you're going to get a whole patient load of people that are going to want to get these pain medications from you. So if you're not prescribing for one person, you're prescribing for 100 people, a reasonable amount, and then the state is going to be saying, oh, this guy is prescribing tons, and that happens to everybody. So you're always wary about what's going to happen to you when all these people come and you get a reputation that you're going to help these chronic pain patients. So and if you're not a quote unquote pain doctor, which how can you be a doctor and not be a pain doctor if you deal with patients in general? I mean, I guess a radiologist, never has to write a pain medication, but
pain doctors do have a different standard.
They're
more. They have more.
They're crazy, in terms of their scrutiny. So, I mean, that's another thing.
But let me just tell you, as physicians, and you're only going to hear it here. So if you're in this chat, guess what? You're getting the inside scoop. We are taught, we are trained in like residency how to different ways to decipher if someone's really in pain. So that's number one. Know that, like most patients, if they come in, they say they're in a lot of pain. Most patients' blood pressure and heart rate will be somewhat elevated. So that's the first thing we look at. Correct, Sasha?
Yeah, exactly, hon.
Right. And then another thing is distract the patient. If they have children, I'll always start to talk about the children because everyone loves to talk about their kids. And I'll ask them to get up on, say, you know, they have horrible back pain. I can't stand that. You ask them about their kids and you're just kind of like, you know, go ahead, get up on the table while you're telling me. And you watch them jump on the table. You know what I'm saying? And then when you examine them, they're like, ow. And it's like, you just basically did a backflip onto this table 2 seconds ago. So there are ways we kind of can tell. And then there's something called a MAPS, MAPS, just like a map with plural maps. It's Michigan something drugs, something safety. I don't know. And we have access to it. If we're suspicious, and it's happened to me a couple of times, probably more to Sasha, but we doctors can get on. You have to give your license number. We go on the website, we type in the person's name, and it shows us the last, like, like what you want to know is when their last prescription for this medication was filled. And like I had one person who literally had gone to 3 different doctors. This was before the opioid epidemic. That wouldn't happen now. Almost everyone does a MAPS now, but and like I was like the 4th doctor, and I was like the 4th doctor in like 12 days or something. Needless to say, she did not get any pain medicine from me. But so we really do have really ways of knowing. And I guess I just feel like if you're not doing that, again, in my mom, like, we are punishing people. And, you know, someone said, like, everyone's looked at like an addict. For not to me, they're not. But I think in the emergency room, that's very true. But anyway, those are our little secret weapons to,
You know,
Okay.
no.
Do you
and
see
then
what
one other
So
thing, I'm
Sasha,
just looking at Angel's
yes.
comment. I mean, she said that she's had some medical issues and she's got some pain, and she probably has some underlying angina that's not adequately taken
Controlled.
care of by her medication. She says that she goes and gets not oxycodone, but hydrocodone from the street. And that is exactly what my wife was saying earlier. People that don't have their pain managed, they'll go and they'll try anything that they can, to help themselves. And it's not, I
Appreciate
don't
the
think,
honesty there, Angel. I really
yeah,
appreciate, this is
I'm not
real
saying,
talk.
as my wife said, I mean, what you just said is clearly what so many people do.
Right.
And it's,
Yeah.
you're trying to get yourself out of pain. And, you know, there, I mean, your doctors aren't helping you, but it's hard to say that. It's hard to come into a doctor's office and say I'm in so much pain, and then the doctor's going to be like, okay, here's all this pain medication, but you do what you need to do to help yourself. And that is,
And I don't think
all of
you're an
us do
addict
that
for
in.
one.
No, exactly. And all of us do that in one way or another. I mean, I deal with, I'm a gastroenterologist, so I deal with all sorts of patients with GI issues, and I will give you stories and tell you tales of all these people doing all sorts of things to try to help themselves. And doctors don't always help, and the way the system is right now, it's stacked against patients in a lot of ways, especially with regard to
But
chronic
it's
pain.
become stacked against us as well, I feel. Like we're damned if we do, and we're damned, number one, do no harm. Okay, but I'm doing harm by not treating my patient. But if I do, I might lose my career. I got live like it's hard. I hate everything about the way it's been presented. I guess the opioid epidemic, and again, like the pill's not an epidemic. It's like a stupid name too. I just I mean when people are in severe pain, and I've been there. I had a hip replacement. But I was 41 and 47, and when my
Yeah,
hip
and then you
broke,
had another one. You're right.
well, yes, and then that one got infected. Yeah. Anyway, but I was in the hospital. They gave me pain medicine because I was there, but even until they got it's a desperation when you're in that much pain. So I understand why people turn to the streets, and I don't think they haven't helped this opioid. They've helped doctors stop prescribing it, which has hurt many patients and caused many to go to the street where it's we don't know what's in it. We know most has fentanyl, and it's not safe, and it's not we're not testing levels of things we normally would test for, and getting urine tests, and it's again I say we've created a new epidemic, and that is pain that's not controlled, and that's not okay.
Are you looking at Carrie T's comment?
No, I'm going to.
Yeah, no,
That,
that's true. I mean, yeah, I mean, it's like sometimes it depends on how
yeah, you're very
much.
sensitive, probably.
Yeah, you're very sensitive, and again, the best example, my wife brought it up earlier, was alcohol. I mean, you got these guys that you go to a bar, and you got these people that can pound 10 beers and drink 6 shots, and they walk out of the bar, and then you have a little old lady or a young person or somebody that's sensitive that drinks one,
Lots of wine and
champagne
right.
glass and is ready to pass out. It's hard to gauge, and it's hard to judge. So that's why a lot of doctors initially go slow, but combination of OxyContin and oxycodone can do
Oxycodone is
what you,
short acting, and
yeah,
Oxycontin
and
is long acting. And
right,
oftentimes, if the pain's severe, they will prescribe it together. The Oxycontin kind of gives a baseline of pain control, and the oxycodone kind of gives little bursts of pain
right.
control throughout. So now,
I
what
will tell
is
you guys,
this?
a lot of the
crap?
stuff that I learned about pain management was from my wife, because she's an internist. She's really smart, and she knows what she's talking about. So
You're not getting lucky tonight, so you can stop.
Okay. What about the kratom? Because I've been hearing a lot about this lately. Does that really help?
I've never heard of it. Have you?
yeah, it's stuff that you can buy at a party store or whatnot, and it's like a
Yeah.
synthetic opioid or marijuana or something. Clearly nobody comes to me in the office and says, "Can I have that stuff that I can get at the party store?" They go get that stuff themselves, and I don't know what they lace that stuff with, and it's just one of those things that is kind of a side.
We don't know. It's not FDA
Yeah,
controlled, so
right.
we don't
Exactly. And the same
know.
thing now with CBD. Who knows what CBD's got in it? And soon they're going to start lacing CBD with fentanyl,
Probably.
and
Oh my God.
it's going to be a nightmare. And
Yeah, it's like they just created a bigger problem. I don't know.
right, and the other issue that's now starting to complicate everything is medical marijuana and legalized marijuana, because that plays a whole role in this whole opioid problem, pain management issue, addiction, abuse, et cetera, et cetera. And at this point, we it's hard to know what to do with patients that are on that. I actually had a patient that lives up north in Michigan that's been my patient for a while, and she was managed initially by a pain clinic, through the hospital that I work at, and then she got her medical marijuana card legitimately because she has issues that the medical marijuana does help her with, and it was a legitimate thing through the state of Michigan, through the government, uh, and she got booted out of her pain clinic, no more refills, nothing, and she was going to go into withdrawal, and I wasn't prescribing her pain medication, but she came to me and she said, I'm dying. I told them I had a medical marijuana card and I need a refill on my pain medication, and they cut me off cold turkey, and that was it. They
That's
were
criminal. That's
no,
criminal.
I mean that's
Just
it
bad
was in her it
overprescribing.
was in her pain contract because they make you sign a pain contract when you sign up for
Right,
these
they do.
pain clinics, and so they had every right to just cut her off, and she was dying, and so I started refilling her scripts, and
She was kicked out
she
anyway.
but and she does, it's not as though she has a hangnail. She's got Crohn's disease and she has issues that require pain medication. So and
What,
she's
what
been my
do
patient for 10 years.
you have any thoughts on medical marijuana as a replacement for pain management?
So I do. So I come up from a very different perspective because I'm more in like the prevention piece than I am the clinical piece.
Uh-huh.
So, I mean, I could see how opioids can be helpful. I also concur that like people are pushed out into the streets to get what they need or what their body has become accustomed to.
Right.
I mean, I agree chronic pain is an issue. I definitely think there's other ways to treat chronic pain. Now, what I will say about CBD, so I actually actively use CBD. I have some kind of like arthritis and joint stuff going on personally.
Mhm.
And I have had really great luck and really good results from CBD myself.
Good.
I
wouldn't
Great.
tell you that.
But I think it's all about finding what you use to treat yourself from reputable sources. Like you're obviously not going to want to go to like any random place to get your CBD. Like I specifically get mine from a company that's sourced ethically and all of that type of stuff. But yeah, I mean, I think that medical marijuana is a wonderful thing. I think there is a significant decrease for a lot of people in pain. I've heard a lot of people
Yes.
that have had cancer that it's brought back their appetite. So that's a blessing.
Absolutely. That's true.
There's a lot of kids that have autism that it works really well with their autism and really brings down their anxiety.
Right.
It can help with depression. If you're getting the right type of marijuana for your ailment, that makes a huge difference too. Like it's not like just smoke anything, more so like, oh, I'm going to get a sativa for this or what have you, all of the different types. I think it's indigo and sativa. But I mean, I think that there's ways that we can treat pain getting away from opioids. I understand that there's extreme cases where people may require something like that, like consistent, constant, back-breaking pain. Yes, absolutely. I totally understand. But I do think that there are ways that we can start to get away from opioids, because what's happening is people, like we said, are just going to the street, and instead of getting their hydrocodone on the street, they might not be able to find it, and then they're using heroin, or then they're using fentanyl or what have you.
And then they get hooked on that.
Exactly.
Which is that's an escalation, an immediate escalation, because once you do that, you're never going to want to go back to oxycodone.
Right.
Or you're never going to want to go back to Norco. You're going to want the fentanyl. You're going to want the
you often become an addict, basically.
Yeah, and then you overdose, and that's the ultimate endpoint. That's how a lot of these things end, and I'm sure statistics will show, over the last probably 5 years since all of this has happened, that opioid overdoses have increased, despite all the attention toward controlling it and minimizing, the minimizing the abuse and prescription of them and whatnot. So,
And I agree with you, Whit. Um, Again, if patients say they take that and it helps, I don't tell them not to, but I can't tell them to. I don't even have a license to do so, nor does Sasha. It's really pain doctors and psychiatrists. So for me, I don't really have much of an alternative unless they're doing it and they say it helps. I don't tell them to stop,
Okay.
but
I mean, I think that it should definitely be an industry that's regulated in order to ensure quality.
well,
what
it kind
medical
of
or
is.
marijuana?
Yeah, medical marijuana needs to be, in my personal opinion, it needs to be regulated if it's going to be used in a medicinal sense.
Right.
And I think it is,
Recreational.
isn't it?
Well, I
yeah.
mean, it's used recreationally now too.
Right. I see what you're saying.
Okay, look at Chris's statement. Well, her question that she put
Yeah.
up. I put up on the screen.
Sasha would know this. I
How
don't know.
did fentanyl become so excessive? One of the ways that it became this excessive is because, as
Got
you
cheap.
have, as you have, used fentanyl patches for, for whatever pain that you had, a doctor will give you a bunch of pain patches, and um, a fentanyl pain patch has got enough fentanyl for 3 days, and usually the fentanyl is 100 micrograms. A typical dose of a fentanyl patch is 100 micrograms for 24 hours. So a typical 100 microgram patch, which is a higher dose of it, contains a ton of fentanyl. So these people will, these street pharmacists will take the fentanyl and, change it, mix it so that they can combine it into other drugs for, to help, or not to help, to get people stoned. But the reason that the fentanyl was supposed to be used is because if you put a patch on for 3 days, that gives an even distribution of pain medication. You're supposed to control pain adequately. It's like a pain pump in the hospital. They put you on a pain pump in the hospital. Fentanyl patches are considered like pain pumps, so it's long acting and it takes care of pain for a long period of time without giving a high, without an acute
Right. No, like big
increase.
bolus or anything.
Yeah, it's not like giving a shot of pain medication in the
Right.
hospital when you go into the ER and you broke your leg and they give you a shot of morphine that takes care of the pain. The fentanyl patch is an even distribution of the pain medication over 3 days. But when you take that, but that's a perfect vehicle to take and use it for or abuse it, because you can take a lot of fentanyl out of that patch and then use it to inject it. And I'm not exactly even sure, because there may be some just like when you have pain medication that's swallowed orally, a lot of is deactivated it just directly into the liver, by the liver. So you have to give more pain medication in order for it to work properly. And I'm
Yeah.
not sure if that's the case with fentanyl patches. So that's why fentanyl became all the rage probably 10 or 15 years ago. That was how we're supposed to control pain. And again, pharmaceutical companies that made the fentanyl patch made a ton of money off of it. So they're telling doctors, yeah, use this patch, it really works well. So we all did, because you always want to take care of patients' pain. And while I'm not a pain doctor, I have a lot of patients in my practice that have bad pain. And you have to try to do everything you can. But now it's like, I most of my newer patients with pain, I defer to pain doctors, because I don't want to have to
Go to jail. Uh-oh.
Okay, that's Sasha.
He
So
didn't want
Melanie,
to have to disappear. Yes.
okay, Melanie. So Dr. Sasha mentioned morphine. When I had my surgery, I can
Yeah.
honestly say that I have an allergy towards
Wait,
morphine.
hold on. I
The
can't
minute
hear you. Okay. Now, when you had your surgery, you what?
I had a reaction to the morphine that they put in the pain in the pump you're supposed to
Something
hit.
is happening. I'm sorry, Heidi. Since Sasha went away, now I can't hear you.
You can't hear me? Okay,
Wait.
Dr.
I'm
Sasha.
back. Can you hear me?
Okay.
Okay. So yes, I was
I can't
saying
hear Heidi. Can you answer her? I want to hear what she is asking.
okay,
When she had her surgery,
when I had
go
my
ahead.
surgery, I had a an allergic reaction to morphine when I hit the pain pump, and I told them I had an allergy towards it, and I guess they didn't hear me. The minute I hit that pain pump, I knew it was morphine. I just threw up all over the place. I cannot tolerate, and I'm trying to figure out why do I have such a bad reaction to morphine. Hello,
I can't hear anyone.
Wit, are you there?
Okay, I just heard
I'm
you say
here.
that. I hear
Okay,
Wet. I hear Heidi.
okay. I don't know where Dr. Sashi went, but
Something's going on. When he comes and goes, I don't know. Uh
yeah, it's not
Oh, I'm
me.
back.
Okay.
oh. Okay. Something. Oh, okay. Now you're perfect.
Okay. So is there, I mean, I don't
Wait,
know
you
why
called
I
me
have this
perfect?
have
Oh,
yeah,
that's great.
No, I was
yeah.
talking to
For the
Heidi.
first time in 20 years, she called me
I
perfect.
actually was talking to Heidi.
Oh, never mind. I'll keep
You're
hoping.
close.
Okay. I want you to look at what Shailene just said. And I've spoken to her several times, and she is in a lot of pain. I mean, I've been talking to her for months. And look
Oh,
at what she's saying.
Shailene. You're not. First of all, you're not alone. I mean, 60% of people with chronic pain suffer from major depressive disorder. So, um, that's unfortunately not uncommon to hear. But have you? Did you ever? Were you getting pain relief and it was taken from you because of the opioid epidemic? I wonder. I wonder if what she's done, what she's tried. See, like I could never, ever leave a patient feeling like that. Like, no, it's not okay.
And I'm serious. She has said this to me. She and I have spoken, and I didn't know she still felt that way, but I can tell you that she is in a lot of pain.
Then maybe you can get my email address from Heidi and we can
I will
talk.
send it to her. Yes,
Yeah.
I will send it to her.
Okay. And I'll give you a call.
Yeah, I will send it.
That's unacceptable to feel like that. That's just unacceptable. My mom did feel
And
like
she's
that.
been going through this for years, years,
I'm sorry
years.
too. I am very sorry to hear that.
Oh, it's heartbreaking. It's like there are a lot of things as physicians, we don't know yet, like we can't cure cancer. We can't, you know, one thing I can do is control your pain, but I am being told I'm not allowed. It's just horrible. And then who said that? Was that Carrie maybe that had a comment that 180 milligram Oxycontin on the street goes for
Yes,
$80? Oh my God.
yes, $80
Oh
on the
my,
street.
for a one pill? Holy crap. Jeez.
And
That,
look what Chris is saying. I mean, I've been reading the comments. I put myself on mute, but I've been reading the comments, and I'm putting up the ones that well, I'm putting them all up there, but I'm reading through them. Oh my God. So she's saying that was the worst thing in her life was to use that fentanyl patch.
well, yeah, again, it's like Some people cannot take Advil and they can only take some people can tolerate and we don't know why, but clearly she should never be on the patch. I know my mom was on a patch and it helped her a lot, and I have quite not a lot, but I think I prescribed it maybe 5 times, and only because when people get into that much pain, even before this opioid crisis, I feel they deserve the best care. And I'm not a pain doctor. But what I used to do, I've been practicing since 2003. What I used to do is give them pain medication to tide them over till they could get in to see the pain doc. I can't do that anymore. I mean, I just, I hope as we're talking, maybe some people can see what a disaster this idea, and as Sasha said earlier, in our training, because we're old, we were taught, there used to be a scale of like happy face. The end was like a crying face, 1 through 10. They'd be like, which one's your pain? And have like different faces. Like, it was like, don't let a patient be in pain. Don't let a patient be in pain. Now it's like, do not overtreat their pain. Just give them just a little, just enough. I don't know where we're going with that. You're not going to become an addict from a couple doses in the emergency.
Right. And what I will tell you in my experience right now is that the doctors of the future are being trained not to use any opioid pain medication. So they'll give patients with horrific pain. There is a syndrome, and I tell my wife this all the time. It's like these patients. I'm a gastroenterologist, so one of the things that I deal with a lot is patients with pancreatitis, and this isn't chronic pancreatitis, which is a chronic pain syndrome, but acute pancreatitis. And
Yeah.
acute pancreatitis is from gallstones. It could be from drinking, but it is extraordinarily painful. It is as if somebody is stabbing you in the middle of your stomach, right between your breastbone, and it goes all the way through, and it's just a throbbing, burning, stabbing pain, and it's horrific. And patients will be in the hospital sometimes for months as a result of this, and they end up, these young doctors that are told, please, don't prescribe pain medication. They give these minimal doses of IV morphine or IV Dilaudid or IV fentanyl, and these patients are sitting in the hospital suffering miserable
Mm.
because they cannot get their pain controlled. And yes, you can nobody's going to become an addict, as my wife said, from a couple of doses of opioid pain medications that control the pain, but you don't send them home with syringes full of
Right.
pain medication. I mean, you don't do that, and no doctor is going to do that, honestly. So yes, you can treat their pain acutely and then back off as they get better, but you do not want to you know overdo it. In the outpatient setting, you do it while they're acutely ill, and then you take care of it. It's just like antibiotics. When you go into the hospital for pneumonia, the doctors will give you IV antibiotics, but nobody's sending you home for a typical, pneumonia with IV antibiotics. Although that does happen, but for a typical person, you end up going home with oral antibiotics for a short period of time. That's how pain medication should be. You should
Right.
treat it acutely and aggressively initially, and then back off. And then, when the patient comes, there's a commercial out here, that says, my doctor, I called my doctor, but he didn't want to give me any more pain medication after my knee surgery because of whatever. manage it that way. Yes, you can do all of that stuff, but there are exceptions, and every patient is different, and you have to treat everybody individually. And you can't have government agencies, regulate how you control patients. Certainly if there are abuses, that's one thing, but for the most part, somebody has
Look what Chris wrote.
something that I deal with. Yeah, Chris has Crohn's, colitis,
A lot of what you deal with.
diverticulosis, multiple herniated disc, bulging disc, and slapped the disc. I'm thankful, doctor.
So, Chris, does
Second
your
month,
doctor prescribe you opioids?
I'm taking her doctor does because she says that I'm so thankful for my doctor.
Yeah.
She's a second mom. She really cares. And then Chris keeps telling us about the kratom.
Care.
Yeah,
Yeah.
I mean,
I'm gonna get kratom, and I want to see what's in it.
Well, I think a lot of places have stopped selling it because people are abusing it. So it's not. I mean, you can get it. You can get it online, I think.
And you can get it in a gas station. I saw it here in Houston not too long ago. It's behind the glass thing, and they have to unlock it, but you can buy it at a gas station.
Yeah, I'm gonna get it.
We'll refer everybody to your gas station.
Yes.
No, don't do that. Not on here.
Just kidding.
Can I address something really quickly?
Yeah, sure.
Okay, so I saw a comment that, to be completely honest, I feel like is super derogatory. It says, junkies ruin it for everyone, unfortunately. I would assume that all of us are not on here to demonize anybody that's dealing with an addiction. So I guess I'm just like thrown off by the comments, because it seems as though we're in these comments, not anybody that's having this conversation right now, but it seems as though there's a lot of demonization of addiction and a lot of lack of understanding that addiction is a disease. That
so I mean, it could have been reworded as, the addicts are ruining it for all. I mean, sometimes it's just, unfortunately, you can become addicted, but it was the addicts who abused it that has led to this.
Right, but in a certain, we also do have to acknowledge that opioids are addictive. There are addictive properties.
Sure.
So with that being said, anyone can become an addict, and it can be, there's nothing that defines someone as an addict prior to their addiction. Like, addiction can happen to anybody. It can happen to the football star that threw out his rotator cuff. It can happen to a construction worker that hurt their knee. Like, this can happen to anybody. So I don't think it's great for us to be demonizing and calling people derogatory words over a development of addiction that they really didn't have control of, because they did have a chronic pain and because they did need to seek out these types of therapies and treatments.
Yeah, you're not wrong. I think it's just, when you're in pain.
But again, it goes back to, that perfect analogy with alcohol that my wife mentioned earlier. It's like a lot of people drink, and they will drink, and they are fine for a long period of time, and then all of a sudden something happens in their lives and they go to excess. And the same thing can happen with opioids and any drug in general. I mean, you could do that with benzodiazepines or muscle relaxants or any other muscle
opioids are not the only addictive drug out there.
No, and I don't think that they are. I just don't think we need to be calling people names for developing a disease that they don't really have much control of.
Yeah, but the problem is people stigmatize people for everything. I mean, look at the issue with I just lost my train of thought. But I mean, everybody accuses everybody. Huh? Oh, hi, AT2.
Yeah, I'm okay. Let me just say, when I used to have anxiety medication, and at one time they gave me is it Buse? It starts with a B. I can't remember.
Buspar.
Yeah.
Or Buspar.
Yeah.
One of
Yeah,
those.
that's what it was. So I would take these pills, after it takes about 7 to 8 days for the medicine to really get in your system.
Right.
So I actually went out to a barbecue. This was when I was in Virginia. I had 2 glasses of wine with the medication that was in my system. I started hallucinating. They had to
Yeah,
rush me to the hospital. They
they
had to pump.
interact.
They gave me chalk. They pumped my stomach.
Yeah.
They came
Charcoal.
in asking me, was I trying to kill myself?
Oh my.
And if I wouldn't let them pump my stomach, they were going to call the police.
Oh
It
my
was an
God.
accidental and it was an overdose of a sort. So since that time, and this has been 20 years ago, I will not drink and take a pill. If I'm on medication, I will not drink.
Yeah, you shouldn't because they do have interactions. I mean,
Yep.
people,
Well,
the
that
birth
taught me a
control
lesson.
pill, like, be careful, you
Yeah.
know.
Well,
Yep. It taught me
a couple
pharmacology.
years
Yep.
ago, I forgot I took my blood pressure medication,
Oh, this
and
was
I ended up
worse when I
passing
skipped my
out.
life.
I took double the dose of my blood pressure medication.
Thank
I
God I'm an
fell out
insomniac.
and broke my face and
Oh my
broke teeth.
God.
Had ended up in the ER,
I mean, I
and
said,
they're
open your
like, "Oh,
mouth.
what drugs
All
did
of
you
his
do
teeth
tonight?"
are
They
broken.
tested me, everything. They drug tested me. They did everything, and they're like, I'm like, "No, I forgot, and I just popped more pills and passed out." And they did,
Sorry
all my
about
drug
blood
stuff
pressure
and
pills.
the alcohol level, all that stuff was negative, and that was it. But that's exactly one of the examples. I said, doctors are suspicious, and
Yep.
I presented with some weird history, and so they're trying to put me, they're trying to take a square peg and put it into a round hole. And
Right.
they did all this workup. And that's what doctors do all the time because, when you have, when you're in a busy ER and you have 20, 30 patients, you're not going to be sitting there and doing, doing a 2 hour history and physical. You want to
Mm.
take care of the patient,
You're
do the
not going to
best
be an
thing for the
annoying
patient.
internist.
Yeah, you're not going to be sitting, I mean, that's, my wife is famous for her, you know,
I have
incredibly
to know everything.
detailed,
I do.
analysis. And I'm like,
I
just,
have to know
what's
everything.
the problem? Let me fix it. And, I'll do what I can to
Well,
take care of you.
but that's the beauty of being a specialist. Like,
But,
you don't
the
only
ER
have to
doctors,
care about their abdomen, what's in
but
there.
a lot of people in the ER community, they just see the patients, they deal with the acute issue, and
Yeah,
the ER
they,
doctors are
they
the
do.
biggest labelers of all, and they're the ones that sniff test everybody, and they sit there and they say, "Oh, this patient is this, that, and the other thing," and it's the furthest things from the truth in most cases
So
because they
scary.
don't know what they're, they just want to take care of the acute issue and move on.
Yep.
But then that becomes part of the medical record. And so you're labeled, you walk in and let's say you took one more oxycodone that you were supposed to, and you're kind of out of it, you're going to be labeled a drug addict.
Yeah,
Yep.
And that's going to
That's
stick
true.
with your medical record forever. And now that, medical records are going through, throughout the country, like if somebody's on the same system as you, it can, if you go to the emergency room in Stanford, you can be on the same medical record as at Henry Ford in, oh, I'm sorry, you guys don't know these hospital systems, but if you're on the Epic system, you can be
Yep. I
anywhere,
know. Yep.
yeah.
anywhere
Well,
in
I
the
have a
country.
doctor in North Carolina who can get my stuff.
Yeah,
So
exactly. So it's like you end up.
it's all like anywhere you go, you're now a drug seeking loser
Right. And so it's
when
going to
you're
be
not.
the
Like,
word of the doctor, who's an ER doctor, who, now that we have a 10-year run of that TV show back in the 90s and 2000s, the ER doctors are
oh,
considered
that's weird.
crazy great doctors. When it comes down,
Wow.
what it comes down to is that they are, you know, kind of vagabonds that either go to or come out of some other specialty for some reason. But they just take care of things right away, and they don't
Not my favorite.
consider. Yeah, no, nobody's
Not our
favorite. Every,
favorite, if you can't
most
tell.
specialists
And that's great, Chris.
and
go on.
most internists just don't consider the evaluation of ER doctors as something that is significant.
They pretty much
you know,
start from scratch.
Yeah, you gotta kind of take every evaluation they do with a grain of salt, but that label that they put on people sticks.
Okay, let me just ask you something because, and this, like Chris said, she had to sign that contract. So
Yes.
I had to be rushed it up. Boy, I'm telling you, I've been taken to the hospital twice in an ambulance. Okay, I told you, Melanie, that time that I flew from Maryland, and I thought I had pulled a muscle because we have been walking all around the mall, which is the big museum area. So at the time, I didn't realize that I was having problems with my appendix. Okay, so I came home. The pain was so severe, I actually curled up on the floor in my bathroom and I was developing a fever. So then I brought my dumb butt to work on that Wednesday. By that Friday, and this was going on, and it gradually got worse. By Friday, I said, if I don't feel any better, I'm going straight to the doctor. Well, at 8:05, an ambulance was at my job.
Oh God,
Took
yeah.
St. John's in Pasadena. I had to do they did the ultrasound first, and then they were going to take me to do the MRI. Well, the nurse came in and she had a little phone, a little micro thing, and it says, cancel MRI, surgeon's on his way.
Yep.
So emergency surgery. He told me if I would have went one more day,
you would have perforated. Yeah.
Yep. So then when they gave me the medicine to come home with, I did have to sign that contract. And, they gave you so much. And, when I would go back in for my checkups, I would bring the pill bottles and they want to see the pills that I'm taking and how many's left if I'm using the correct dosage. And my question was, since you said that everybody's history is in the system, would the fact that I had an accidental overdose could have been the reason why I had to bring my prescription pills, the bottles with me?
Very well, might be.
Yeah, and they also want to check to make sure you're not selling them. I mean, because that's the big thing. I mean, people ask for more pain medication than they need, and then they sell.
Now that I know for one pill it's $80.
Yeah.
Right.
And
sure.
I don't like taking medicine because all it does is it makes you sleep. It puts you to sleep. You wake up.
I wish I had medicine to put me to sleep.
I'm serious. The medicine they gave,
I know.
It
for
makes
most people, it does make them sleepy.
And I wake up 4 to 6 hours later, pain's there, take another pill. I don't like that. So with you, I was mad because you didn't follow your doctor's orders. But I'm like you. I don't like taking a lot of medicines. I just don't. It's not me. I don't have an addictive personality. I just don't like feeling like I need something that's just me. So am I wrong for doing that? For not following, like when they tell you finish the whole bottle? Because I never do.
Only antibiotics.
Okay.
Only
But the
antibiotics.
pain pills are always take as needed. Take as needed.
Right.
Take as needed.
No, you've got to take all your antibiotics to make sure there's, you don't get what's called a secondary infection, that you actually kill all the bacteria. Like with strep throat, it's a 10-day course. You better take it for 10 days or you could get rheumatic fever. You're feeling better in 5 days. So just your antibiotics you really need to complete. Everything else is pretty much, But I was going to say, Heidi, two things. One, imagine, how the pain you're in and laying on the bathroom floor, no temperature, but just an agony. Imagine living like that all the time, and then you can't sleep because of the pain, so you never get a break from it.
Never.
Sherilyn I think that Sherilyn, I just see that, she's trying to sleep through pain, and Mina.
But a lot of people cannot sleep through the pain.
Right. And then I saw the comment that Mina made, and she's right. I mean, people, of color, they're not treated the same way. They're judged. They're not treated the same way. And one of the things that actually really, if anybody should complain and and report to the government, it would be those sorts of situations where somebody is, I
Gotta
mean,
do
it
something
may
for
be
you.
a secondary issue, just like, the issue with people of, with people of color, and the police, people of color with the medical establishment, they're judged in a different way than,
Not, and again, we should say not every doctor.
no, not every
I
doctor, but like in
promise
ERs,
you,
a
on my
lot of the times
children,
that's the
I do
case, and
not treat
especially in
any
like inner cities too.
patient different, no matter what. I do not. And I know Sasha, and I know I have friends and they don't, but I do know some that do. And again, it just is so unfair. And
And you have no
that's
resource. You can't
that's
be like,
what the systemic, what's meant when we're trying to teach our kids what systemic racism is. It's like, they're like,
it's
well, I
pervasive.
have a lot of, they're 15 and 16, and it's like, yeah, there's like these little things that you don't see that they do, and like this is another one. But um I mean, that could be a whole show in and of itself.
Right.
But
If you're
it's
ever looking for a good book to read about like health disparity and health inequity in the Black community, there's a book called Medical Apartheid. It's super interesting, and it just talks about a lot of the things that have happened in the United States, like Tuskegee and things like that.
Yeah, the Tuskegee experiment was a horrific thing that, that it was that experiment, has tainted, African Americans against the medical establishment for years. And
I mean, people aren't getting COVID vaccines.
Exactly.
Yeah, that's why there's so much vaccine hesitancy.
Right.
Yeah, among the
Black
African American community. Yeah.
I get it.
And this Tuskegee, I mean, it is, and if you read all of the information about it, and you cannot believe what they did and how they dealt with these people over years. It is, I mean, it truly is criminal. I mean, all of those people that did that, it is horrible. I mean, it is at the level of what the Nazis did at the Holocaust. So
yeah, I mean, there's other situations and other instances of this happening in the United States. Like, for example, with the smallpox inoculation, Thomas Jefferson actually like experimented on the people he had enslaved at Monticello.
Oh, lovely! I didn't know.
So some of the first trials
I agree.
of the
It's
smallpox
unbelievable.
vaccine. Yeah, so I understand the vaccine hesitancy, but that's a whole different component. That book is just incredibly interesting. And they do say, there's a significant bias against people of color in the medical field. Unfortunately, they say something like 67% of doctors think that that Black individuals have a higher pain threshold than white individuals, despite there being no scientific evidence, which I think is really wild.
Well, Whit, that's funny you said that, because I told Dr. Melanie earlier, I am so sorry. I'm going to try to be professional while we're on
I
here.
don't care. Come on, I don't care. I know
Dr. Melanie.
My friends call me Melanie, and we're all friends
okay.
here.
Well, when we're having phone conversations, it's Melanie, but now you're Dr. Melanie. Okay. So I told Dr. Melanie earlier, I have a very high threshold to pain. And did I not tell you that?
Yes, you absolutely did.
I mean, not to pain, to medication. So I was telling her when I had an accident in Virginia.
Said, you got started on. I go, we don't start you at the highest dose. She's like, oh,
yeah,
they do it with me.
But he did, and then he only gave me 2 pills. He said, take this, break half of it. If you're still in pain within 2 to 3 hours, take the other half. But I couldn't he only gave me 2 for a 24 or 36 hour period because I was in so much pain, but they didn't know what to give me because they had given me other things. It didn't work.
And it was before Oxycontin. What was it called?
Yes.
Sasha might have heard. I never even heard of it.
What's it called?
It was the Secanol or Secanol, something like that.
Oh, that's actually a barbiturate. That's not an opioid. You know,
Okay. Yeah, I
it
didn't know.
actually is designed, and they used to be used as a sleeping pill back,
For
back in the
sedation.
day.
Yeah,
So he was trying to put me to sleep instead of helping my pain, basically.
Yeah, but you know
pretty
what?
much.
Pain can be helped in multiple ways. I mean, first there's the nonsteroidals that, in your presentation you talked about all these non-opioid ways to manage pain. It's true. Nonsteroidals like
Motrin,
aspirin or
Aleve,
Motrin or
Aleve.
ibuprofen, Aleve, they do handle muscle inflammation and back pain and things like that for the majority of people. You know, and when people are in pain, there is a tremendous amount of anxiety that goes along with the pain. When somebody, I mean, think about this. When somebody puts a, in a situation where somebody puts a gun up to your head, and threatens to shoot you, there is absolutely no pain, but the anxiety level is huge. And that plays a horrific effect on somebody's psyche. But pain does the same thing. You know that this pain is coming, or you have this pain, and it's a horrific, anxiety provoking effect on your body. And Secanol will actually help that because it calms it down. So it does help calm down pain. So you could use a combination of that plus a low dose opioid or anti-inflammatory. All of those things, can be done. So there are multiple ways to deal with things other than using opioids, but opioids really work, and that's why they've been around for thousands of years. And
Okay.
nobody's contesting the fact that there's an opioid problem and an opioid epidemic and overdoses, but
Oh,
part
I
of
am
that,
contesting there's an opioid epidemic.
but you're right, but
That's
it
what this
is
whole show's
just
about.
no, but there is, people use a lot of opioids, but we shouldn't just not use them, but we should
Abuse
use.
of opioids, perhaps, but opioids in and of themselves, I mean, they are
No, I don't
still
think that. I
FDA
do it
approved.
myself.
They're not off the market. What are they,
Right,
just sitting on the chart on the shelves at pharmacies to look pretty?
right. No,
I
you're
mean,
right. You're right.
it's ridiculous. And just so you know, and Sheila, I don't know if you know this, and it's a kind of a vicious cycle because when you have a lot of pain, you can't sleep, and sleep deprivation causes increased pain quite dramatically, and dehydration as well. And when you're really in a lot of pain, you're not eating and drinking much, and so it's this vicious cycle.
Yep. Melanie, where did you go?
Mel?
Hey everyone, I'm gonna hop off.
All right, Wet. Thank you
All right,
very much for coming on. I
Yeah,
appreciate it,
thanks,
sweetie.
Wit.
absolutely. Have a good night, everyone.
All right, baby. Bye bye. I have to find out. Okay, she says she never buys. Yeah, something happened with Mel. She says she's not, but crazy.
I think your phone died or something. Hello? Am I the only one still on? Heidi?
Guys still hear me?
I can hear you.
Yeah, but
Melanie
see, I'm
says
not
she's
saying.
backstage, whatever that means.
Okay, I'll bring her back up.
Oh,
I'll bring her. Oh, okay, there she is. But yeah, that was okay, Mel. I mean,
Yeah.
Dr. Melanie, I have you. But
Okay.
so I saw somebody said that they were allergic to weed. I don't know if I'm allergic to it or not, but I know when I smell it, I get a really, really bad headache.
Good.
I really do.
I mean,
And
well,
what is pain somnia? That's what I wanted to ask.
you can't sleep because
well,
the pain's so bad.
yeah.
Okay, that's
There's
what I
like,
thought.
I think she kind of made it up, but to mean like you can't sleep because of pain.
Okay.
Whoever
And
just
then
said that stealing my term, please do. Which
and then
everyone
you have
call it
Shay-
opioid abuse.
okay, Shaylin is asking you a question. I don't know if it's for you or not, but it's called second sequinoid. Is that real? I don't know who she's talking to right there.
I, I don't.
I don't.
Maybe what you were taking. What?
Yeah. Well, it was real. That's what they gave me, and he actually took my weight, and everything, and he gave me the highest dose that he can give me because everything else they had given me was not working.
Right, and that
So
happens, and and that's when you have to go to something that works, and it's often an opioid.
okay, she's asking you to tell her exactly what it is. Maybe it'll help her.
A barbiturate, you said, Sasha?
Barbiturates, yeah, that's like
It's
oh
kind of like a benzodiazepine, like
yeah, they're
sort of
similar.
like
I mean, they're
Valium
similar. That
or
no, what is the
yeah,
I haven't prescribed one in.
yeah, me
I think
either.
I'd prescribed one in my entire life.
Okay,
What's the common one?
Dr. Sasha was talking about something
Hold
for
on, I gotta
that.
find my phone, honey. Is the my phone? My phone's in the room. Hold on.
Okay,
I'm
I don't
signing
know.
off for a minute. I'll be right back.
You're not signing. You're walking away for a second. Sasha, I think he was saying, a barbiturate, years ago, um, maybe would be appropriate with a low dose opioid,
Okay.
but
And
you
guys,
can't
I'm
get an opioid
sorry.
anymore.
I'm sorry we're going in and out, but the winds here are really bad. We're under another thunderstorm warning. It rained for the last 2 weeks. Seriously, rain pouring down, and I'm scared we might have another Harvey because when Harvey happened, it was happening the same way. Rain, rain, and then it just continuously kept raining and it flooded everywhere. Couldn't get out anywhere. So, but I don't have to go out, so I'm good.
We had storm.
Yes, AT, yeah, I see that, but I moved closer to the router as well to make sure. That's why I have my picture up because the lighting and everything is in the living room and I didn't feel like moving. So, okay,
Okay,
the
I'm
Dr.
back.
Sasha, here's the question for her. I mean, here's what she's asking you. I put it up on the screen.
I thought you were saying it in reference to what Heidi, like a low dose
Like a
opioid with a barbiturate.
barbiturates, barbiturates can deal with anxiety and um. Hold on.
But nowadays we use benzodiazepines. So
Yeah,
sometimes it's
you know,
appropriate to give someone a benzo. I mean, I get very anxious when I'm in pain, which, as you all know, just happened. Like
you know.
it, it.
Go ahead,
I don't
babe.
know. I no, just I mean, so I'm guessing, Sheila, you must have a lot of anxiety.
Yeah,
Oh
she
well, your
has anxiety as
doctor.
well.
I
I mean,
mean, there's tons. Anxiety.
Klonopin.
I think is probably well. I mean, Klonopin's good, but that's kind of an atypical benzo. Hold on. Let me just. Sorry,
I would
guys. I'm going to talk to
I
Suri.
would prescribe you Valium
No,
or
that's fine.
Klonopin because like Xanax works for anxiety, but it's shorter acting.
Barbiturates.
Um,
Yeah, I don't take Xanax. I have Zertaline. It's another word for and I take that very, very seldom. But when I was at work,
Yeah.
I would get to the point where, and I knew I would get up in the morning and know it's going to be a bad day. So I'm going to pop one of
yeah,
those anxiety pills
Okay.
yeah,
because
So here's the typical prototype for barbiturates, which like morphine is the prototype for
an
opioids. The
opioid.
prototype for barbiturates is phenobarbital. It's
Like,
used and it has been used for years. It was
years.
a
epilepsy,
medication,
because my mom takes it for epilepsy.
right? And
Yes,
and
yeah,
and
yeah.
and just like you can use a benzodiazepine like Valium or Ativan for seizure disorders, you can use phenobarbital. That's one of the alternative treatments. It used to be used earlier, in the in the last millennium, back in the 90s when I trained. But it is, it's still used, and it's used to actually get people off of, when people are abusing uh, benzodiazepines, they use that to help get them off it. They can also use them to get people off of alcohol when they're using a combination of things. So, a lot of the outpatient
But that's not what
rehab
they usually
centers.
use.
No, for
You know?
alcohol they use Ativan, but like in the outpatient facilities, they'll use a lot of those benzos, and phenobarbital is one of them. So, but that can be used, but you have to have somebody that knows what they're doing with it. It's not something that, a typical, like I said, I've given one script for phenobarbital in, the 100 years that I've practiced, or, well, 25. So anyhow, so.
Okay, look at Shailene.
Yeah,
Shailene she just made that statement too. I'm definitely, Shailene, I'm going to send you a DM, and I'm going to send you Dr. Melanie's email,
yeah,
and
I
then
do whatever I can.
Yeah,
communicate.
Dr. Melanie is the smart one. She tells me everything that I know.
That's so not true, obviously.
Now, I had to, my mom had this after she had her back surgery, and she still takes it right there. She still takes this. But
Trazodone?
she,
Trazodone's great.
Are we talking about trazodone or phenobar? What are we talking? What does your
no,
mom take?
okay, my mom has phenobarbital. Oh my God, she takes this pills for epilepsy. She takes 4 of those a day. 4 a day. Then she has the trazodone, and then she takes something else. She has a whole list. So whenever we go to the doctor, I bring her medical thing, her little kit, and they go through everything. And they're like, okay, reduce this. Okay, don't take this anymore.
Right.
Yeah. So we go through it,
And that's-
especially when she goes to her heart doctor. Yes.
Yes. Trazodone is a great medication for sleep. It's not an opioid, and it's not a benzo. So, if anyone has trouble sleeping and their doctors are, gun shy about prescribing something controlled, trazodone for everyone else in the world but me works.
Oh my gosh, she said use
and you can pronounce it too, because there's so many medications that I can't pronounce. I like to write the medications that I can pronounce. Like trazodone is good, but phenobarbital or buprenorphine and those other medications, those are hard to pronounce. Just kidding.
I have on Ambien.
Okay, guys, do you have any more questions for Dr. Melanie or Dr. Sasha? We've been on, and
we
can
want people to
always do
watch
this again.
this. Yeah, because if
Yeah,
it
we
goes
can
too
always
long,
do it
people won't
again.
watch
And,
it.
and I think we're gonna do like ask the doctor, if they're up to it. So, but we can do that in a couple of weeks, so they can come back on and
that's
get to
easy.
questions.
I'm happy to
And that way, but this was a topic that we
whatever
really could discuss. And
thank you, Heidi, for
no, thank
discussing
you
it.
for bringing this to me, because
this is a very important topic.
It is, and I'm very, very, as you can tell, passionate about it.
Yes, but it's just with everything that we've learned tonight, what I'm looking at is the government is stepping in. They're trying to regulate things, and there's a lot of people that's going to pay the price for what they're doing. And you have the people that abuse the system that is really hurting the ones that really need that medicine, especially your mom. I
would probably still feel, I'm sure I'd still feel the same, but to see it in my own mom, like she was in pain, you don't become pain free on these things, but it's manageable. And she worked and she drove and she came over here and saw the boy. And eventually I got her a new doctor and she was able to get back on it. But she couldn't go on the porch to water her flowers.
Yeah, but
for no reason. She had back surgery, severe degenerative joint disease. Like it was no joke. She had to have surgery for it, and it didn't really help. And the answer was, well, let's cut her off then. I mean, it's just, but it was horrible. It's horrible. And I don't like Shaylin feeling like,
Oh, Shaylin, no, baby. I'm gonna just give me a few minutes after I end the live. I'm gonna send you her email address, and you can reach out to her. And she's really, really a very smart woman. She's
existing.
and yeah, so she'll be able to talk you through it if you have questions for things that your doctor hasn't checked or hasn't thought about. Maybe Dr. Melanie can help you, and you can bring that back to him. So
absolutely, I'll do what I can.
yes,
I want to know
but
what you tried, what we're treating.
Yep, and that way you can talk to her about the different medications and everything that they have tried, and maybe she can give you some suggestions. But I just want to say thank you, Dr. Melanie, Dr. Sasha, Whit,
Our
and
pleasure.
Whit has. I'm telling you, this woman has a wealth of knowledge on everything. So I always love to hear what she has to say. But the kratom, we're definitely going to have to look into that because I've heard a lot of
I'm
people
all over that.
saying
I
about
saw
the
it
kratom.
times.
Yes, so.
And I can
But
only
we're
see
gonna,
the comments you're putting up. I'm sure there are more.
well, I put all the comments up, all of them, so you guys can see them.
Good.
Yeah. Yes, I did. I put everything up. And I want to thank everybody for sticking with us and being here through all of the spinning and the freezing. And I'm so sorry, but I didn't want to cancel again because we've been trying to do this for a while. But
yes, I'm glad that we did it. Sorry, I'm hiding. And
no,
by the way,
it's okay.
ladies,
I'm hiding now too because it's dark in my room.
Man up there is taken.
Yes, Brad Pitt up there.
Brad Pitt is taken. It's my Brad Pitt.
Dr.
All right.
I really thank you. And Melanie, Dr. Melanie, I want you to take care of yourself because I don't want to get no more text messages from Dr. Sasha about you being in the hospital.
I don't want to
Okay.
get yelled at anymore. All right.
I love you guys.
Love
thank
you.
Good
All right.
night.
Bye, guys.
Everyone.
Thank
Good
you.
night.
All right. Bye-bye.
Bye.